I have one other method that I mentioned in my book, and this sounds gimmicky, but I think it works. If your vendor uses the word roadmap, that is your triggering. Listen for that word, because roadmap, if a vendor says roadmap, what they mean is we don't have it. We are possibly maybe working on it. It'll take at least 18 months. It's always 18 months. Believe me, roadmap is always 18 months. But we don't want you to go buy this somewhere else because it's on our roadmap. I think roadmap should be a trigger word for any health IT consumer, right? Any one of the leadership team, a consumer, to say, great, you do your roadmap, I'll buy something else in the meantime. That, to me, is the strategy, and I hope that all my listeners, as soon as the word roadmap comes up, fine, we will do a third-party vendor while you work on your roadmap, and if 18 months, 2 years, 3 years later, you come up with an equivalent version, great, we will consider replacing it.
Welcome to Beyond the Blueprint, a podcast designed to empower healthcare professionals, enabling them to improve care delivery through integrated design and technology innovation. My name is Greg Malkery, and joining me is my co-host Keith Washington. Whether you're redesigning a hospital, launching a new digital initiative, or just curious about the future of healthcare, then you're in the right place. Let's explore together what's possible when we go beyond the blueprint. Good afternoon and welcome to Beyond the Blueprint. We're going to explore how modular IT can help hospitals break free from rigid vendor systems in order to move faster, work smarter, and to deliver better patient care. Hospital CIOs want more flexibility, clinicians want tools that actually work, and the C-suite wants results. Unfortunately, a tight and flexible technology stack around the EHR is slowing everybody down. Well, to help us break this down, our guest speaker, Dr. Harm Scherpbier, is a renowned physician, educator, and now author with his recently published book, Unvendor. In his book, Harm challenges how healthcare leaders think about technology in order to build smarter, more flexible systems to support transformational change. Harm, welcome back to our show. I believe this is actually your third episode with us. We kind of think of you as family. Can you start by sharing a bit about your background?
Yes, thank you, Greg, and thank you, Keith, and it's great to be on the podcast with you. I was the CMIO, Chief Medical Information Officer at Mainline Health System in the Philadelphia area. And before that, I worked for a number of health IT companies. So while I'm trained as a physician, I spent my whole career in health technology and health and digital health. And at the outset of this book, which is called Unvendor, I encouraging or appealing to my partners, my peers, health IT leaders, CIOs, CMIOs, to leave that single vendor mindset behind and to move toward a more open, third-party, innovative structure. And I have to say there that I implemented single vendor EHR systems. So I know why we're doing that here in the Philadelphia area. I understand the benefits of having a single vendor system, for consistency for users, for ease of integration, for collecting all the data in one place. I understand that. But I think we've reached a point where the benefits are not completely there anymore, and we start moving into disadvantages. And one of those is innovation, the ability to innovate fast. There's no way. Innovation is going so fast these days with AI, with devices, with other technologies. It's coming at us so fast that a single vendor cannot possibly be up to date on every one of those technologies and deliver them to their clients. So that's where I think we are now at a point that health systems should start incorporating modules, applications, tools from third parties to be on the cutting edge of technology and to be innovative. So that's one of the reasons I wrote this book. The second is innovation is fast. The second is the business model in healthcare is also changing. We're still shifting away from fee-for-service care toward value-based care, and that is accelerating. Also, it puts pressure on health systems to be competing with value-based care practices in the area. To me, that is an important driver, and I don't want our health systems to be waiting on their EMR vendors to enable that change. So changing business models is also a reason for faster innovation and allowing for third-party components into the health system ecosystem. That's why I wrote this book.
Keith, do you have any opening remarks for our audience today?
Well, thanks, Greg. So for anyone that might be joining us for the first time on Beyond the Blueprint, we look to bring together thought leaders to explore innovative design and use techniques to manage complexity that it can enhance patient care. So I think today's topic really does address complexity. Obviously, the tech stack, integrating the tech stack is a very complicated endeavor. So looking forward to this conversation and looking forward to, helping our leaders listening in how they might think about, design and systems and integration to start to develop best practice and what it means to their organization.
Hey, thank you, Keith. Now, before we dive into today's discussion, I want to recognize our valued sponsors who've made Beyond the Blueprint possible, Storage Systems and Simplify Medical. With their support, we're able to bring you insightful conversations around healthcare design and innovation. If you enjoyed today's show, I encourage you to subscribe so you never miss a future episode. To go back, I know we just talked a little bit about Harm, what some of the drivers were for your book, but your career, you actually started in clinical medicine and later transitioned into health IT. What really inspired you to actually write this book, and in particular, write it now?
Yeah. As I mentioned before, I spent my whole career in health IT. I worked for a number of EHR companies. I worked for a population health tech firm. I teach health informatics and population health at the Jefferson College of Population Health. And that is where I, of course, keep up to date and track the development toward population health and toward value-based care and how that changes the way people work. So my belief is population health, value-based care is a business model. That business model drives the care model. We are seeing care models in the US change, monitoring larger panels of patients, using multidisciplinary teams to track panels of patients. And that requires technology. That's all based on digital health to be able to do that. So, as I said before, I know there's advantages to single vendor systems, but there are 4 reasons. Let's unpack that a bit more. Number 1, innovation. Faster innovation requires at this point bringing in third-party tools and modules. That's number 1. Number 2, competitiveness and flexibility. I think our organizations cannot wait until my big vendor finally delivers the function for me to be competitive. So competitiveness and flexibility requires that we bring in third-party tools. Reason number 2. Reason 3 is user experience. We all know that these large EHRs are extremely expensive. $100 million more, billion, sometimes $2 billion for a health system. And yet, it doesn't take much to ask a user, what do you think of the system? And you would say, meh, not great. They're not enthusiastic. They're not super happy. Some are, but overall, users in these systems are not very happy. They're not saying, I am so efficient. This is so fast. And to me, $100 million investment, you better have happy users. And we don't. So to me, that user experience is another reason to start exploring options that create better user experience also on the patient side. So that's reason number 3. And finally, the 4th reason is cost. These systems are so extremely expensive. I think for health systems to be competitive and to start competing and negotiating with these EHR companies to say, we're going to drop the cost of health IT, you got to start thinking outside the single vendor box. So 4 reasons: innovation, flexibility, user experience, and ability to reduce the cost of health IT.
Is there a direct channel going back to the CIO, from the different end user groups, which could be across clinical operations or business? Does the CIO tend to take this into consideration as they continue to make additional investments in this single vendor strategy?
My book is written specifically for CIOs, for chief medical information officers, for chief nursing information officers, but also I think for chief medical officers, chief nursing officers, chief executive officers, actually for any healthcare leader, because I think IT is too important to just leave up to the CIO. The IT is how an organization works, how everything that happens in an organization goes through your IT system. So I think it's too important to just say the CIO will take care of it. I think this is a much broader team that should start thinking about what is the future and what is the strategy in our IT digital stack and in our health tech for our organization, because it drives everything. In my book, I compare the information system as a neural system, right? It's your central nervous system. It's your peripheral nervous system. Everything the organization does is somehow driven by the information system. That's why I think, yes, CIO, but also yes, all the other C-suite executives in the hospital.
Do you think you could share an example of a healthcare organization that didn't replace its EHR, but added additional tools around it to make or increase its utility?
Yeah. That's a good way to put it. And in my book, I tried to phase it in multiple steps because I don't think this is an all or nothing approach. This is something that you start and then do a bit more and then do a bit more. And every time you step it up a bit. So I have a number of starting points, fairly obvious add-on applications, great ways for health systems to gain experience in incorporating third-party tools. Easy. Next level up, a little bit harder, larger modules that require a bit more integration, that are a bit more significant, but also are strategically very important to the hospital. Then lastly, as the last most ultimate step here, is to actually start replacing health IT function from the vendors. Start by adding on, start by supplementing, and then finally, down the road, start by actually replacing functions. So, to name a few examples, is that okay, Greg? Can I just a few?
Yeah, no, actually, it's very useful to our audience.
One, and that everybody's doing today, but it's a good place to start, is ambient clinical documentation. Meaning, in a patient-doctor conversation, the microphone listens for the conversation and using AI tools generates the note. It is most health systems today are implementing this and are rolling this out to their doctors, and that makes total sense. Interestingly, there used to be 1 or 2 large vendors delivering this technology. Right now, there are over 50 companies that provide this function, which tells me that this is a fast-growing market. If there's 50 companies and you just signed a contract with one of the big expensive ones, you might as well start looking for some of the less expensive ones. That price needs to be coming down. So I see no reason for health systems to not say, fine, let's incorporate some of the lesser cost, but more fast-moving, smaller companies. So that has become a very interesting place. I think that's if an organization isn't currently rolling out ambient clinical documentation to their entire team of doctors and possibly nurses, that's where they should be starting. But that's just step 1. Population health and value-based care systems. I mentioned to you the business model is changing. I think if you're at all, as a practice or as a health system or as an organization, are in the value-based care contracting business, you need the software to support it. Without the software, you cannot make it work and you're going to end up losing money. So to me, that is a very obvious next step. Many of the big EHR vendors have population health modules. In my experience and in my clients' experience, they tend to be insufficient. And I think it's worth looking at stronger, more effective tools to handle a panel and a population. So that would be an obvious area number 2. Robotic process automation, completely different tool that helps improve and speed up organizational processes. That could be administrative work, billing, revenue cycle, and it could be clinical work. I recently did a panel at HIMSS using the team from New York University Langone Medical Center. They are heavily investing in robotic process automation and are being very successful both on the administrative and clinical side. So I think that's another great area. Device integration. We'll talk about that more later. In the old world, data came from the lab system. Today, data come from all kinds of tools and systems. Patient-generated devices, glucose monitors, smart stethoscopes, smart ultrasounds, data come from. There are so many devices that produce data, and we need to retool our environment to be able to capture the data from all those devices. I think that is another area where one vendor cannot do it all. You need to bring in all these tools. So those are some examples in several stages that help you start easy and then move forward.
How would you recommend healthcare organizations today who are stuck in this one vendor controlled system, which actually is a very common theme, at least the CIOs I talk to? What's one practical step? Now, you pointed out something earlier, which I thought was quite interesting about this is not just about the CIO, but this is actually about a cross-functional team. What's one step they can take today to be able to start moving forward toward a more flexible IT infrastructure?
Yeah, it's taking some of the steps which I outline in my book. I don't think this is all or nothing. This is something you start with some straightforward, not too hard to integrate systems, and then you move forward. Now, one thing that happens while you do that is the organization will start investing in modern interoperability tools. Interoperability in the old days was HL7, connecting systems using HL7 interfaces. That's still there. That will still be there. The new interoperability, and everybody knows this, is based on FHIR-based APIs, FHIR, Fast Healthcare Interoperability Resources APIs. That, to me, is a space that all the EHR companies have invested in. They support it, but many of the health systems haven't quite embraced that technology and says we are going full force into using FHIR and the APIs to connect our modules in the hospital. To me, that is the CIOs and CMIOs challenge to say, let's start investing in there, become really good at it. Now, while I'm saying this sounds simple, I don't think it is simple. I'm not underestimating the effort it takes. I think while FHIR has been around, the adoption is still lagging. And that, I believe, is something that only we health leaders can change. If the adoption is too slow, let's start using it. It's like use it or lose it. And that's the same thing with FHIR-based interoperability. I think it's time for us to start using it in order to become good at it and also to force our vendors to support it in a 100% strong way.
So it sounds like you really need to have a certain motivation and drive towards standardization and governance, right? Unless you have that from the top down, it might be very difficult to translate or transition to a truly modular IT infrastructure.
Yeah, I think that you're absolutely right. It has to be strategic. It has to be led by a governance team. All the Cotter steps of organizational change apply to this project, obviously. But let me reemphasize strategic. We're not just doing this for the sake of doing it. So as a health system, pick a problem that is actually real, important, significant in order to fix that. Don't just say, okay, let's find a tool just so that we can gain some experience. No, pick a strategic problem that could be clinical documentation, that basically translates to physician and clinician burnout. Let's implement ambient clinical documentation, population health, robotic process automation. Let's pick a very important, significant topic and fix that using this interoperability. So it needs to be a strategic problem. Therefore, let's tie to that. When you find your problem, connect that with specific targets. Targets for achieving either a return on investment or, I prefer to say, value on investment. You cannot always express the benefits in dollars, as in return on investment, but in healthcare, often you have to say value on investment. So if at the end of the day, I'm able to give back my clinicians 30% of their time by reducing documentation, that is value on investment. And I think as you pick your strategic goal, also set your strategic VOI targets so that you can track the benefits of the project. That's governance.
Excellent. I actually like your last point you just brought up, which was good, is don't just try to do a rip and replace, but try to get some milestones and some successes under your belt that are in alignment with your overall vision. And it could be a multi-year effort because you certainly spent, $100 million or even $1 billion on your system.
Yeah. I agree. Multi-year. This is not something you do in a weekend. This is kind of the go forward strategy. I think that's what I mean by this. We have reached this single vendor point after many, many years, but it's solidly ingrained right now. And it's most large EHR companies are in this mode. So it'll take years for us to move over to the next stage, and that'll take years, but that's okay. I think this is a matter of starting and moving.
Do most leading healthcare systems, do they have the right skill sets within their teams to be able to transition to a more modular system? For many of them might be with a leading edge EHR, there's a certain expertise they had. But now that you're bringing in third parties in order to support the overall technology stack, do they have the right skill sets? Are there things missing like API development?
Great question. I'm going to answer it in two ways. First of all, yes, interoperability. And I mentioned this in my book. We need to invest in interoperability. We, health systems, need to invest in interoperability. We traditionally, because of the single vendor mindset, I think have underinvested in interoperability. That needs to go back up. And I know that health systems struggle with staffing and struggle with cost, but I believe that the benefit of bringing in these third-party tools will handsomely pay off the investment in interoperability, skills and teams and experience. So that is very, very important. At the same time, health systems also worry about their end users and how they all need to be trained. Kind of feel that we reached a point that we do not need to be so worried about our end users. Every clinician, every person, every doctor, every nurse, we live in a digital world today. So I don't think we need to extensively train every user on every component of the tool. If it requires that much training, it's probably not a good tool. We are used to living with so many electronic tools that typically we quickly figure it out and know how it works. So I would say push more toward interoperability and focus a little bit less on training and education, because that should be fairly self-explanatory to most clinical users today.
Well, as you pointed out, the ambient listening, like the tools need to be able to actually enhance workflow, right? Maybe with this next generation of AI tools, which actually might fall in well with the whole idea of a migration or transition to a more modular architecture.
It's funny that you mentioned it, Greg, because 2025 HIMSS conference, there was a lot of discussion about the benefits and experiences with these ambient listening tools. And One thing that doctors very quickly figure out is to say, if I need something to be in a note, I need to say it out loud. Obviously, right? I need the microphone to pick it up. So doctors very quickly are learning that instead of dictating my note, I just need to make sure I say everything to the patient. So I'm going to be very specific about what are we deciding? Here's the plan. Here's your medications, which is perfect. That is exactly what we should be doing. So I think it's a win for the users. It's a win for the patients, and the documentation becomes faster. So users figure this out. I think this is, they very quickly figure out, how do I optimize the use of this technology?
One last question, I'm going to hand it off to Keith. A Clinician Class report published a paper on single vendor versus best of breed. Is the industry going back to best of breed? Because I remember it wasn't that long ago where we're directly migrating away from that strategy. What's the current trend going on?
I think that is exactly the right question to ask, Greg. I think Class wrote this report. It's an interesting report about single vendor versus best of breed. I'm not saying we're going back to best of breed. This is not a pendulum swing. Where best of breed is a station we passed. It turned out to be unmanageable. No, I believe we're going forward to the next stage in health IT, and that is, to me, a platform-based infrastructure. So these large systems will not go away. Obviously, we'll still need our large EHR and revenue cycle infrastructure, and they will become platforms that handle the core activities inside a health system. But on top of that platform, we will now start inserting and supplementing third-party modules, tools, applications to extend the function of the platform. To me, it's not best of breed. It's a platform-based architecture that will be the future of health IT. As a matter of fact, the large EHR companies, big Oracle Health, they want that. They see that as their future. They state that as their direction. So in other words, I almost feel like these large EHR vendors need health leaders to help them move in that direction, so they can focus on the core business of the health system, but can allow a variety of innovative tools to sit on top of the platform. So that's not the same as best of breed. It's a forward-thinking platform-based strategy.
I like that. I'm going to take that to my lunch coming up today. With that, I'm going to hand it off to Keith, because I know Keith probably has a lot of questions to ask you on some of these topics. So Keith, why don't you feel free to engage with Harm?
Thanks, Greg. Yeah. So Harm, of course, I appreciate you gave me a copy of your book. I got a chance to read it. I really appreciate your perspective. I thought you created a great anthology of kind of how we got here, like a lot of detail in kind of the history and the kind of the technology underneath, and kind of where we are today with this tech stack, this idea of a tech stack. So I think, as you mentioned, your audience right now, would be, say, a CIO of a large IDN, something like that, where you have thousands and thousands of stakeholders, maybe even millions in the population you're serving in a market, in a community. I guess maybe think about beyond that. Just say, if you're a large IDN in a market, and you're working with sort of like the physician office and the urgent care and the local pharmacies and everybody else in the community, I guess, how can they think about this opportunity to maybe take advantage of all these tools, all these technologies? It seems like we have an abundance of tools, but we're trying to find, we're the craftsmen that know how to use these tools in community, in a market. How do you think about that?
Yeah, no, you're right, Keith. There are, of course, so many different technologies. Again, I'm referring back to HIMSS. Look at the show floor at HIMSS. There's so much that we can buy and purchase and pursue. So 2 things. First of all, of course, be strategic about this. Don't just look for a tool for the sake of a tool. Find a problem that you're dealing with in your organization and find the tool that serves that problem. So I think we talked about this. Be strategic about it. Set your targets for ROI, VOI. I have one other method that I mentioned in my book, and this sounds gimmicky, but I think it works. If your vendor uses the word roadmap, that is your triggering. That is your trigger event. Listen for that word, because roadmap, if a vendor says roadmap, what they mean is we don't have it. We are possibly maybe working on it. It'll take at least 18 months. It's always 18 months. Believe me, roadmap is always 18 months. But we don't want you to go buy this somewhere else because it's on our roadmap. I think roadmap should be a trigger word for any health IT consumer, right? Any one of the leadership team, a consumer, to say, great, you do your roadmap, I'll buy something else in the meantime. That, to me, is the strategy. And I hope that all my listeners, as soon as the word roadmap comes up, fine, we will do a third-party vendor while you work on your roadmap. And if 18 months, 2 years, 3 years later, you come up with an equivalent version, great, we will consider replacing it. I also mean by roadmap that you don't need to sign a 10-year contract with another vendor. You can do a 2-year contract, right? you don't need to always say the only thing we do is 10-year contract. So do a short-term contract with an interim solution that helps you pass the roadmap, learn, gain experience, get ahead of yourself, and then possibly transition. To me, that's a tip to health leaders. Listen for that word and act.
Yep. No, very cool. Yeah. And I think, as you said, give credit to the large EHR vendors. They would like to see things improve just as much as the health system and the physician, everybody else. Like we're part of a big ecosystem.
Yes.
And so sometimes it's just making sure that there's good communication back and forth. But I do feel like there's a certain role then for the entrepreneur and all that. Like, as you said, the disruptor, the innovator, somebody who might be able to take more risk. How do you feel about, we talked to a lot of our vendor partners on Beyond the Blueprint. You feel a sense of everybody wants to participate in this path towards innovation, but maybe they lack some of the skills. So we've been talking to some of the physician entrepreneurs of the world to say, look, you have a unique perspective. You've kind of grown up in a clinical environment. You're sort of tech savvy because you've known tech your whole life. How would you advise a physician entrepreneur as to maybe what to focus on to kind of take advantage of this opportunity you're describing?
Yeah. Well, before I answer your question, I think you said something important. I am not at all anti-vendor. As a matter of fact, I'm a big fan of the fact that we moved from paper charts about 15 years ago to fully electronic records and having no piece of paper. That is, of course, a huge achievement, and I'm happy about that. And I think our vendors play a very, very important role in running our health systems today. So while my book is called Unvendor, I mean with that, single vendor, right? The vendors play a huge role, and I'm hoping to get us out of the single vendor mindset. And from a physician or executive or innovation perspective, I think I want to go back to the beginning of our talk. Innovation is moving so fast right now, powered by AI, but also powered by other infrastructures and technologies and sensors and devices. It is moving so fast. I think that is on the one hand could be paralyzing to an executive team like this coming at me, could be paralyzing, but I think it doesn't need to be paralyzing. Pick one or two things and start moving in the direction. I'm going back to my theme here. You don't have to do everything all at once. Pick one or two projects and start with that. Gain experience, build up your team to say, now we are really getting good at incorporating tools. And I think what I mean by that is you will start seeing the organization move from a single vendor, monolithic organization toward platform-based agile organization. That's, I think, what we're looking for. And that starts with a single step. That's all we're doing.
Time to wrap up. Keith, would you like to make any closing remarks today about today's topic?
No, thanks, Harm, very much for your time. And I do appreciate your perspective on the vendor and the roadmap trigger. I think those are very insightful takeaways, so that by no means does unvendor mean anti-vendor. It means it's inspiring for leaders running large health system organizations that patient success, patient care is their primary role responsibility, and they're the craftsman and the vendor is the tool. And you've got to keep those things in proper perspective. So I really think that your approach is spot on. I really appreciate the hearing about all the complexity and what it's going to take to kind of get leaders to put all these pieces together, think about upstream and downstream consequences of all of it, thinking strategically, having a plan, but then picking something and keep moving forward. Like speed is really important. I think all that's great. So I want to just thank our audience for taking the time and hope they're inspired by this idea, right? That look, if you're a leader of an organization, the health system, and you're trying to take care of patients, then this is your responsibility. Like you've got to take that responsibility seriously. And there's a whole bunch of technologies and tools out there that can help you, but only you are the one right now driving that ship in that direction. So appreciate that perspective, Harm. I think it's really insightful, and I just hope your book does really well.
Thank you. My book, I hope that your listeners will read my book. The full title is Unvendor, Innovate Healthcare with a Diverse IT Stack. It's available at all online bookstores, and I look forward to your feedback.
Well, Harm, also, how can folks get through to you if they want to reach out to you?
LinkedIn. I'm the only Harm Scherpbier on LinkedIn. And in the back of my book, I also have my contact information. So after reading, I'm hoping that this is part of a conversation. This book is meant to be a discussion, a conversation. So I left my information in the back of the book to say, please let me know what you think. And also, please let me know what you're experiencing as you start doing this. I would like to hear the stories and incorporate that into a dialogue and a conversation with health systems in the US and outside on how they're moving their IT stack forward to a more diverse and innovative IT environment.
Thank you very much. This is awesome today.
Thanks, Harm.
Thank you. Thank you, Greg. Thank you, Keith.
Thank you for listening to Beyond the Blueprint. Together, we're exploring how thoughtful design can simplify complexity, enhance patient care, and create meaningful change. If you found value in today's episode, make sure to subscribe and leave a review in order to help us continue the conversation. Let's reimagine healthcare together on Beyond the Blueprint.